Good afternoon and welcome to ICE webinars. Today we are joined by Randy Parker, Lead MR Safety Officer at Corewell Health. Randy has over 10 years of MRI scanning experience and over 4 years of experience with duties and responsibilities as an MRI Safety Officer. So thank you, Randy, for your time today. Now, just a quick reminder to save the date for our 2026 ICE Expo, which will take place at the San Antonio Marriott River Center on the River Walk Hotel in San Antonio, Texas, from February the 20th to the 22nd next year. Now, the Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. So for more details, please visit attendice.com. I'd also like to announce that ICE Magazine is excited to announce our first annual Diamond Awards. In December of 2025, we will announce the 8 imaging directors or managers who have been nominated and chosen by our ICE audience. To nominate an individual or yourself who you feel should be highlighted for their great leadership skills in the imaging healthcare field, please visit the icecommunity.com/ICE Diamond. Now, deadline for nominations is May the 16th. Okay, today's webinar is eligible for one ARRT Category A CE credit by the AHRA, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your credit, and you'll be able to download the certificate directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Okay, let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. March is Colon Cancer Awareness Month, so what colour ribbon has become the universal symbol of colon cancer? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, Randy is our presenter today, and he will be discussing Beyond the Magnet, building a strong MRI safety culture with radiology leadership and team support. So Randy, you may begin whenever you're ready.
Great, thank you so much. Good afternoon, everybody. I want to thank ICE Magazine for having me back to speak with you again. We have a good one lined up for you today, so hopefully we can avoid a sophomore slump. I always want to share my appreciation for you logging on today as well and attending the webinar. This lecture is titled Beyond the Magnet, Building a Strong MRI Safety Culture with Radiology Leadership and Team Support. Let's get started. All right, so I am Randy Parker. I'm the lead MRI safety officer at Corewell Health West. I am a certified MRSO by the American Board of Magnetic Resonance Safety, or ABMRS. I'm also a member of the International Panel of Experts for Care Reporting, and I do have to disclose that I also am an expert consultant or witness in legal proceedings. So the objectives for today, we're going to review and identify key components to align with best practices to provide MRIs safely, understand the significance of collaboration in problem solving and the impact of an effective communication, the impact that effective communication can have on maintaining a safe environment. We'll highlight ways in which radiology leadership plays an important role in not only creating but harboring a culture of MRI safety, understand the importance of reporting adverse events, and we'll discuss how to develop checks and balances to promote adherence to the standardization of safe practices within the MRI department. With that said, for today's agenda, we'll define a few key MRI safety roles. We'll talk about MRI safety education, and we'll have patient screening, different things like that. We'll talk about a MR safety call to action that we have put together. And so with this, we'll go through and highlight some of the things that have resulted since that call to action meeting that we had, and just what we've done to help maintain things as intended. So as mentioned, we hope to have a few minutes at the end for discussion. So I want to be respectful of everybody's time. So if you can just please put any questions that you have into the chat function, that would be great. All right, so I'd like to remind you of some key roles that you'll want to consider for your own MRI safety program at your sites. These roles were first established and defined in 2014. They became board certifiable titles shortly after when the American Board of Magnetic Resonance Safety, or ABMRS, was established. Since then, I believe about 3,500 to 4,000 MRI professionals have been certified in at least one of the top 3 titles. These individuals are the subject matter experts that are crucial to your program. The safety associate at the bottom there, it's not an official title. It's one that my organization uses when referring to certain technologists. If you'd like to learn more about these, I did go into more detail about each role in my previous webinar, which can be found on ICE Magazine's YouTube channel or by going to icewebinars.live. All right, so here's an example of an institution that has a system-wide MRI safety program. There can be different variations of the structure, but this is how we've established it at Corewell Health West. In an effort to meet the needs of our diverse patient population, many of which are underserved due to implanted complex medical devices. This list of experts here in the middle column was established to create, implement, and maintain necessary policies and procedures based on or directly derived from best practices named in sources like the ACR manual on MRI safety. You can also find what your role may be if you're within the administrative role within radiology. Many of our radiology leaders are members of what we call the Expert Improvement Team, or EIT. It's similar to a committee or a subgroup with a focus on MRI safety-driven operations within their respective departments. You'll also see throughout this webinar that our radiology leaders played a very key role in the things that we did that I'm going to talk about today in our lecture. So before we go on, we want to recognize that a few key critical components to reducing adverse events within MRI and keeping MRI safe is proper physical layout or zoning, access control, education, and proper patient screening. These components can be challenged by an increased demand for MRI services, as well as the number and complexity of the implanted devices that are coming out nowadays. Okay, so what today's webinar is primarily going to be focused around is a healthcare provider's system-wide MRI safety call to action. So what is a call to action and why would we use it? So basically they are methods to raise awareness on issues that are occurring within a certain department or within a certain team, especially when it comes to safety. If there's a safety risk involved and there's something systematically that's potentially causing this issue, we want to be able to identify that, and we do that by having these call to actions, and this also gives us the opportunity to get feedback from our team members so that we can see areas of improvement. Now, when this was first brought to us, it had only been practiced in the surgery space, and to my knowledge, that's still the primary use for it, is within the surgical space. What we did for this one is we modified it to focus on thorough safety screening, proper visual inspection, and their roles in preventable zone, what we call zone 4 infractions, but basically MRI adverse events. We emphasized that many healthcare errors were the result of systemic or process problems, not due to a specific person's behavior. That was very important when we set out to conduct these meetings. And we also wanted to emphasize that most adverse events that occur in MRI are preventable, with, of course, that level 2 MRI staff member being the last line of defense. And we also wanted this to be a show of unity. And I'll actually reference this again later on, but essentially we wanted the um, staff to know that by us coming to them and asking their feedback, their opinion on like, hey, we have a safety issue, we see a safety issue occurring, or we see a trend that we don't like that puts us at risk of a safety issue. What can we do to help you uh, prevent that from happening? So we wanted this to be a show of unity for the staff too, to let them know that when they take the time to do the what are considered the best practices to prevent a safety event, we wanted this to kind of be a symbolization of us standing with them, and so they didn't have to feel um, that they needed to rush or cut corners or something like that. We wanted them to know that when you take the extra couple of seconds to do things the correct way, if you get pushback from a provider or a patient or something like that saying that you're taking too long, or hurry up, scan my patient, when you are in control and you take control to make sure you do things correctly, these meetings and these call to actions were a way to signify that we stand with our staff when they choose to do the right thing. So the idea for these meetings had been in talks for several weeks. The plan was to conduct them at some point in 2023. We started talking about these towards the end of 2022, but nothing was really in motion yet until this happened. So to summarize, the MRI department was getting ready for a long general anesthesia case when an inpatient nurse called down to ask MRI when they were going to fit their patient in. It was a simple MRI brain without contrast, so the MRI tech thought he could just squeeze it in before everyone came down for this, complex general anesthesia case. This did occur at one of my facilities, by the way. So the not wanting to delay the upcoming case, the MRI tech rushed this patient into the first available MRI machine, which just happened to be their 3T, and didn't perform a proper screening with the patient, who was alert and oriented, so they could have been properly screened. It wasn't until he had been scanning her for about a few minutes that he decided to open up the patient's chart and saw that a patient had a defibrillator implant that was documented on all over the place. The MRI screening form, it was documented within there's an implant section of the patient's chart within their EMR. It was documented in there. He immediately stopped the scan and got the patient out of the room. Fortunately, the patient appeared fine, but because the implant wasn't properly programmed for the MRI and it was scanned on the wrong magnet, it was only conditional for 1.5 Tesla. The tech decided to scan her on the 3T. The functionality of the ICD was unfortunately permanently damaged. By the way, this patient had a heart transplant 2 years earlier, and the ICD was in place to assist in rescue efforts should there be any issues with the donor heart. Thankfully, there was no harm to the patient, as I said, and it turned out that her heart function had improved so much that they had elected not to replace the defibrillator. They decided that she didn't need it anymore. Nevertheless, this event sparked an immediate response that escalated our plans to the forefront to start these. So at my institution, we have a pretty robust internal reporting system. Part of my role as the MRSO is to review any submitted events for MRI, particularly zone infractions, and help determine the cause and label them as either preventable or non-preventable. I also review any good catches that are submitted, which is by far one of my favorite parts of my job. I love showcasing our good catches by our amazing team members and their leadership. As a matter of fact, we now have a way for us to be able to reward a technologist for submitting a good catch using it. We have like a points system, within our organization, and you can accrue so many points and turn those points into, turn those points in for actual gifts. And so we've had that in place for a while, but we just got approval to be able to start using that for when techs submit good catches. So I have been just absolutely elated by that. And we actually had our first ever MRI safety good catch of the year. We started that in 2024, and so that showcased, there was about 8 or 9 good catches that we were able to kind of whittle down and have as nominees, and then put it out to all of our MRI staff and all of our managers to vote on over for a few weeks. We put it out in a poll, and whoever got the most votes, they got a bunch of these points. The MRI techs got a bunch of these points, and then they also got some praise and notification, or praise in our monthly newsletter, on our internal web page. So just really tried to go out of our way to make them feel special. But anyway, so having said that, I've found great value in reviewing both good and bad events, because each presents learning opportunities for myself, but most importantly, our teams. That's why I summarize our reported events every month for all of our MRI employees to see, good and bad, respecting the privacy of the individual reporter, of course, if it was a Zone 4 infraction. And secondly, we take a non-punitive approach to reporting mistakes. We encourage our techs to report mistakes, because we know that it is the only way that we will learn about them and learn from them. For example, if a tech scans the wrong body part, you don't need the tech to report it in order to find out about it. All you have to do is look at the images taken. But for the most part, you can't look at an MRI image and see that the patient wore their jogging pants into an MRI machine and now they have a thermal burn, or that someone brought an unsafe object into the room, or that a patient is still wearing their hearing aids or a glucose monitor or something like that. The only way that you're going to find out that something happened is if somebody reports it. That's why we don't discipline those who report. Why would we want them to be afraid of reporting if that's the only way that we know that these things happen? The tech who fried the patient's defibrillator that I just told you about, he not only immediately filled out an event report, but he also emailed his supervisor, his manager, and myself right away. He already knew what he did wrong. I didn't need to regurgitate that. But what I did tell him, and everyone else, when I've used this as an example, is that if he would have just taken another minute or two to screen the patient, or at least look at her chart first, he likely would have caught the implant and not put her in the wrong scanner. I made a point that it took him at least twice as long to fill out the event report and write that email after it happened than it would have been just to screen her properly. So please encourage your techs to report, and do your best to remove the fear of doing so. I've even had to fill out reports on myself. I've actually had 2 incidences now where I walked in once with an old Fitbit watch that I forgot to take off before giving a safety demonstration to new hires, by the way. And I didn't realize until after the demo was over. And then it happened again about 5 or 6 months later. I had a different watch, and I just completely forgot to take it off until I started feeling that thing pulling towards the scanner once I got up close to the mouth of the bore. And I immediately took it off and left the room and had to report myself. So now with all that out of the way, what originally started the discussion of doing the call to action was a retrospective review of our MRI events. So we looked at the 45 infractions that were submitted between the beginning of January of 2021 through the end of January 2023. We found that 31 of these events were preventable, or about 69%. And some of the common incidences that occurred were hearing aids, glucose monitors, ancillary staff equipment, like somebody leaving their phone in their pocket, or maybe they walked in with an unsafe badge reel, a watch or a Fitbit, patient clothing containing metal or jewelry, different things like that. And it's important to note that when we're discussing these things, I will specifically call out if there was any sort of patient injury or anything like that. There in these events, there was no actual harm that came to a patient or anything like that. There may have, there damage to certain devices, such as hearing aids and glucose monitors and that type of stuff. So certainly there was device damage. But as far as any patient injury, fortunately, we have not had any of those when it comes to these incidences. What we also found in our review is that 74% of the infractions, we noticed that either metal detection was not used, which we did have at all of our sites at the time. It was either not used, or a thorough visual inspection was not performed properly or at all. On the flip side of that, we also reviewed 52 good catches, in which we found that in 19 of them, that was done with the help of metal detection. So about 37% of the good catches were as a result of using the metal detectors. So our ask of the MRI team was that when we did these call to action meetings, we showed up at the site, and this is what we asked of them. All ambulatory patients are to be wanded prior to entry to Zone 4 with our handheld metal detectors. Immobile patients immobile outpatients or inpatients that aren't able to stand or sit up and be wanded, a visual screening is needed. And then we even broke it down to, basically lay out what a good visual inspection looks like. Well, it looks like the patient being properly changed into hospital attire. They check the patient's hair for any metal garments or bobby pins or scarring or anything like that that could indicate a prior brain surgery. They check their ears for hearing aids, medicine patches, like those nausea patches behind the skin. They check for jewelry. They inspect the shoulders, chest, abdomen, and back for any unsafe stickers, pumps, monitors, certain types of wearable devices. And then lastly, visualize and palpate certain areas to look for pulse generators. Typically, these are in the muscular tissue, and unless you're a patient of size, typically these protrude out from the skin, just like the picture there on the right. So then we asked our team members to openly air out any of the concerns, questions, and suggestions they had about these requests. We visited all locations, including the several that were already doing well and had compliance with these practices. We wanted to know what the team thought has allowed them to be successful, and if they had any suggestions for the teams that were struggling. So the method is myself, as well as representatives from risk management, process improvement, quality, safety, and experience, and radiology leadership, rounded to all of our MRI locations. We met with MRI techs. We met with the radiology RNs if they're, usually routinely working down in the space. We met with tech aides, or people, techs from other modalities that can sometimes act as tech aides for the MRI staff. And these typically lasted, the meetings were supposed to last about 30 minutes altogether. We, as the visitors, were meant to speak for about 10 to 15 minutes. And then the meeting was meant to be turned over to the staff and meant to be staff driven from there. There was a scribe person there on location to capture any notes or feedback or follow-up that we wanted to have in the meetings. And some meetings actually went beyond 30 minutes. Some of them went up to 2 hours, which was it was a great conversation. We did make a point to try to work around the patient schedules of each site. So that's why we wanted to try to keep it to 30 minutes so we could minimize how many appointments we had to block. But of course, they either sometimes went long or sometimes were shorter than that. And here's kind of an Excel spreadsheet that we put together to kind of help track out and help coordinate each visit for each particular site. So you can see every site up here in the top row. And then we identified, people, physicians, if they wanted to be involved. Our MRMD was on site for several of these. What the local, myself as the MRSO, and then we would also try to have the local MR safety associate, the MRSA, or if there was a local MRSO that was kind of my point person, we tried to have them on site. We tried to have the director or operational leader there, and then so anytime that we were putting together and trying to coordinate an appointment or a meeting, we tried to identify all of these key players to make sure that we were staying consistent across the board and that nothing was missed. And then you can see down there at the bottom, we kind of had worked out, the days and times that we were going to go to each site. So as I mentioned earlier, there was a scribe person there for each meeting. Now I know you can't read this. This text is super, super tiny. But I just wanted to kind of give you guys a visual of what the kind of where all of that information, all of those notes ended up, was in a spreadsheet somewhat like this. And they were not all colored at first. It wasn't until that we started looking through the comments that we started to see some trends. And so we decided to organize the feedback by common themes. Remember earlier in this lecture that I had mentioned a few critical components to reducing an adverse event in MRI is proper physical layout or zoning, access control, education, and proper patient screening. Notice what the top 3 areas from the feedback from our staff were. I swear I did not put this together. I did not foreshadow this, in the slide earlier. I didn't even notice that this was a connection until I was prepping the speaking notes for this meeting, or for this talk. Now, the physical and structural barriers could be anything from we need some signage in the dressing room explaining why patients need to change their clothes, to a full, complete renovation of the MRI department. As a matter of fact, a complete reno is exactly what happened at one of our sites, and that work actually finished in January. I have a few pictures that I'll show in a few slides. And then we also have another location that is slated to start a complete renovation for them later this year. So the reno was already planned. In this case, the reno was already planned at the time these call to action meetings occurred. But in the next slide, I'll show an example of another change to a physical department that can be done at any MRI location. It doesn't require any major renovations or changes. The request for education enhancement wasn't so much for the MRI techs, but to increase awareness for safety risks for ancillary staff like patient transporters and EVS staff, nurses, but also for our patients. For example, there were several recommendations to make an MRI prep video for patients to watch as part of their pre-visit instructions that would explain what happens. And we do utilize a third-party vendor for a such type of video. But there was actually some conflicting information on a couple of the slides that were creating some frustration and points of conflict between the patient and the staff. It would say, like, in one slide, it would say you're going to be asked to change into hospital attire, and then in the very next slide, it would say you may not be asked to change, so just make sure that you wear something comfortable and doesn't have any metal snaps. And so, of course, the patient would hear the second part and then show up and would be frustrated, when they were asked to change their clothes. So just kind of different things like that too, is what we focused on too. There were several questions about, excuse me, that is why the patients are not surprised. That way the patients weren't surprised when they were asked to change their clothes, or they were asked several questions about their medical history, because they would see this video and kind of know about these things in advance. There was also an ask to standardize what a proper visual inspection was, which is one of the main goals to these meetings, thankfully. The hope was that by addressing the top two issues, the third most common issue would be vastly improved. And so far, that does appear to be the case. Um, we've also found a common theme among the strong MRI sites that had done well. We had actually had 7 locations where in 2023, and some of which were known to go multiple years without a single infraction. So 7 locations had 0 infractions for the year 2023, and some of those had gone multiple years. The team members stressed that good teamwork, communication, and two-way accountability were big reasons why they were to be successful. In these teams, there was no egos. One tech wasn't afraid to ask their partner if they had screened their patient before they were about to bring the patient in. Essentially, the second MRI tech or personnel acted as another final checkpoint for the primary tech and their patient. So if you need another reason to have your MRI room staffed with 2 personnel on top of it, being one of the key points in the ACR manual and things like that, here's another reason. Because you can have that second person act as another final checkpoint for you, to make sure that you kind of checked all the boxes before getting that patient into the room. Anybody can get thrown off of their normal routine, myself included. And when I was a scanning MRI tech, I was the lead tech at my facility. I had no problem whatsoever with my coworker saying, "Hey, did you wand your patient? Did you screen them? Are they changed?" I had no problem in that. As a matter of fact, I took comfort in it, because I knew that there was a good chance that if I did get thrown off somehow, they would be there to remind me, and they would have my back, and I would do the same for them. Document on the far right, facilities inside the dressing rooms. So we have dedicated dressing rooms for our MRI patients, and in there we have posted laminated copies of these documents. Essentially, this is just explaining why we're having the patients change their hospital attire and remove any metal, different things like that. So the document on the far right here, this was actually created by the ISMRT Society, and so it wasn't a document that we made, but we got approval to use. And then the middle picture there that you see, this is actually a snippet of the internal training modules that we have for several departments within our organization. So we have our level 1 and level 2, just your general level 1 and level 2, and then we've also broken out the level 1 training to and customize them to more align with specific departments like security, EVS. If we have at one of our places, or at a couple of our sites, we have nurses that are staffed down in MRI 5 days a week, and so there's I've carved out some additional content for them within the annual training. Same thing for respiratory and anesthesia. So those are just some of the things that we've tried to do to help with the education piece, especially for the staff that work around the MRI department. So commitment to our institution from a facility standpoint is pretty incredible. The resources and the revenue that we've invested into our MRI sites help garner safety and alignment with best practices. Our focus is also to combat the unconsciousness that patients, visitors, and outside staff likely have about the safety risks of MRI. So, if you think about it, there are plenty of situations where the staff may not realize that um, there's a danger, or may not be aware of the dangers of the area, and so we try to do things to help curb that. Things like putting in badge readers that restrict access to both Zone 3 and Zone 4. For example, a level 1 trained RN that typically works down in MRI may be granted badge access for Zone 3, but there's often no good reason for them to have free access into Zone 4. If they're working with MRI staff, the MRI staff are going to be there to allow them access into Zone 4. So there's, in my mind, there's not a good reason for them to have independent access. Let me get this. So this is another example of an event that occurred at one of my facilities. The picture that you see on the left there is a anesthesia cart that was attracted to one of our scanners back in January of 2015. And hopefully this will show that it didn't take this call to action for us in leadership to put an emphasis on MRI safety. As soon as this event happened, there was discussions about the department itself, and what had possibly led to an event like this happening. And they realized that the department could stand to be better organized and have a better structure to allow for to garner those safety practices. So here is that very same hospital back in, I think it was 2022 that this went live. So it was about 6 years later. Of course, it was delayed because of COVID and things like that. But this is the very same hospital. So they have a proper holding area now. They're not just having patients hold out in the hallway. You can see the decals on the floor that represent the area that the staff will have the patients stand to get metal detected with our handheld metal detector. So different things like that. And then there's more ample space between the Zone 3 door and the Zone 4 door as well. Here's another example. This is actually the MRI site that I spoke to earlier that just finished their completely new renovation earlier this year. So beginning of January is when they started accepting patients. This is a site in particular that would make my heart palpate when I would go to see them before. The reason is because they actually had direct access into Zone 4 from Zone 2. So, and what made it even worse is at the time before we were able to really restrict the access into the Zone 2 area, literally everybody in the hospital had access to that area. And so that meant that literally anybody in the hospital could potentially make their way into Zone 4. So it was just a huge, safety event waiting to happen. And because of the importance that we put on MRI safety and the recognition that we had of the inherent risks that was involved in that old layout, they dedicated resources to have the proper zoning, the proper badge access restrictions that you see here. So another thing that I talked about is having a good communication, or like a two-way accountability with the staff that were doing well at the strong sites. And so one of the things that we put together was essentially like an MRI tech peer-to-peer review and what this was for is for basically for you to be able to, if you're an MRI tech working with another MRI tech, you could kind of use these aids as kind of like a guide sheet, just to make sure that you're doing everything that you can to prevent either a zone 4 event or to prevent a thermal event. So you can actually see there that I've broken them out into separate things, because oftentimes there are different practices that are going to specifically prevent one thing over the other. So we've kind of laid that out here. So this would be completed regularly, and we have also talked about having the ability to incorporate something like this into the EMR, so that the tech has to select that this is done for every single patient, and that's something that we're looking into this year. All right, so what we did after these call to action meetings were completed, what we ended up doing was we kind of developed action items that were derived from the patient or from the team members' feedback. And we had a total of 51 items that were received. Most of the items were completed. As of fall of last year, we had about 48 of those that were completed. Some of those were pending the completion of the renovation project that I just showed you. But in total now, we have completed 94% of those tasks. Majority of these were completed between April 2023 and October of 2023. In the next few slides, I'm going to show you how addressing these issues affected our adverse events afterwards. So you're about to see the number of reported preventable events at our institution. Again, this is for, I didn't specify this before, but this is encompassing 17 MRI locations and 22 scanners. So for comparison, this line graph represents the reported preventable infractions for 2022. So this was the year prior to our call to action that we did. You'll see what we had: 13 events reported, but we also had 3 confirmed MRI thermal burns that year. For 2023, we had 22 reported events, which is 9 more than the previous year, but we also had 0 thermal burns. And again, it's also worth noting that aside from the defibrillator incident, none of these events resulted in patient or staff harm or significant equipment damage. Notice how we started the year and the trend downward, particularly in the region that we started to do these call to action meetings around April and May. Now remember, we completed the majority of the action items between that 6-month period, and you can kind of see a downward trajectory reflected there. Lastly, here are the numbers for 2024. So this graph looks a little wonky, kind of, up and down, but one thing that I took note of is we had 0 months where we had more than 2 preventable events, whereas previously we had several months where we had 3 or more preventable events each month. We also had 5 months in 2024 that had 0 preventable events. So we finished the year with 13 total preventable infractions. This was a 41% decrease from 2023. So do you remember this slide from earlier where I talked about the reported events that we had reviewed in advance of the call to action meetings? Let's pluck out this information here from these slides and remember these as we move on to the next little bit. So I took it upon myself to actually run this kind of retrospective study, if you will. I took it upon myself to run this again, focusing on the last 2 years. So from February 1st of 2023 to the end of February of this year, we reviewed a total of 147 reported events. We did have some exclusions with this one because we did start we did start incorporating another region of hospitals that I wanted to exclude from this study just to kind of make sure that we're comparing apples to apples. So we had 40 exclusions. On top of them, having the other region incorporated, the exclusions also included whether they were simply scheduled at the wrong location, if the patient didn't bring their programmer for their stimulator, or if the patient was upset about, patient procedure, about safety procedures, or if it was something like, screening x-rays were already ordered, and they were, reviewed and found to be negative. So I wanted this specifically to focus on what our asks were with the call to action. So that was proper screening, visual inspection, and wanding, right? So because of that, we excluded 40 of them out. And then it's broken down a little bit further here where you can see that of the good catches, I'm sorry, this was the good catches, not the adverse events. Of the good catches that we had, there were 54 of the 107 that we decided to include. Those were caught by proper screening and a good visual inspection, or about half of them. And then metal detection was responsible for 37 of the 107, or about 35%. And then I did also want to note here that we did have 11 that were caught just by simply the technologist reviewing the chart in advance, or reviewing prior imaging in advance, which is a good practice to get into. That did account for 10% of our good catches from that time period. Now here is the reported adverse events. So the total preventable zone 4s from the same time period, there were 42. We excluded 9 of them. They were excluded because they were from the other region that we didn't have previously. And in reviewing those infractions, we found that proper screening or visual inspection would have prevented 9 of the 33, or about 27%. And then same for the ones that would have been prevented had the patient been metal detected, or metal detected properly. And then also, again, just to note here, prior imaging review or chart review could have potentially caught 3 of the 33 of them. So here's it laid out in kind of chart form, or table form, I should say. So you can kind of see the total numbers here. This is the data pulled from the initial slide that I showed you. So from 21 to 2023, this was the numbers here, and these are the numbers from the following 2 years. So remember that, so this starts in February 1st of 2023. We started doing our call to action meetings in the middle of March 2023. So about 6 weeks into this data range. So you can clearly see the amount of infractions that had occurred were 57. So that number was actually up by 12 over the compared to the prior year, but the amount that were preventable had decreased by 11%. So it was 69% preventable previously, and that had dropped to 58% for the last 2 years. In also comparing whether or not the asks that we had, the call to action items that we wanted the staff to perform, that we identified and asked the staff to perform, the amount of those that could have prevented the preventable zone 4 infractions also went down by almost 20%. And then what was most encouraging is the amount of good catches that have been recorded in the last 2 years have literally doubled, going up by 55. And then what's even more, what's just as kind of astonishing is the good catches that were caught by these things that we identified and asked our staff to do, and worked with them to either change their layout, change their processes, or do something to help support them so that they could do these things. The good catches that were as a result of these before the call to action were 19 or 37%. That jumped to 91 out of the 107 for the previous 2 years, or for the last 2 years. So that's 85% of the good catches that have been reported since we've done these call to actions, and since we've supported our techs in doing these things that we identified as best practices. That has jumped to 85%, or an increase of almost 50%. So I'll leave you with this. With zero to very minimal government or agency regulation requirements focused on MRI safety, it is up to the facility and its team to implement best practices that will prevent incidences from happening. It's on you to establish a culture of safety within the MRI department. All right. I want to thank ICE Magazine again for giving me the opportunity to speak to you today. Thank you all for your time and your attention. Should you have any further questions after we're done today, or if you'd like to simply discuss the presentation further, please scan the QR code here, and that will direct you to my email address. I could talk MRI safety for the rest of the afternoon if you let me, so please don't hesitate to reach out. And again, thank you.
Thanks, Randy. That was great. We've actually got a couple of questions that have come in. The first question is, what has been the feedback from your staff or patients regarding the physical changes that you've made to your MRI departments?
That's a great question. So if I would have had the ability to pull our press Gainey feedback and our scores since changing the physical layout, it's been nothing but positive. Particularly those sites that had undergone significant changes, but even the ones that had minimal updates to them. There have been significant changes in the patients that have had issues. There's been a significant change in the habits that the technologist had. So for example, at one of our sites, the environment kind of garnered some bad habits with the MRI team, that when they moved to their new space, some of those things that they'd actually had to take some time to kind of get those bad habits out. For example, having a proper screening area for the patients. The techs didn't have to walk in and just verbally screen the patient as they're walking into zone 3 and zone 4 anymore. They actually could take the time to sit the patient down, screen them, do a proper interview, different things like that. So really the response from both the staff and the patients has been positive. The staff hopefully also feel more supported, because if they do have a sort of if they have a combative patient, or they have somebody down there going, oh, come on, why do I have to do this? One of the things that they can do now is, point to the signs that we've put in the changing rooms. We've also had our policies updated to reflect patients need to be changed and different things like that. So they can reference things like, hey, this is our policy, or hey, this is, it's right here hanging on the wall. This is why we have you do this, as opposed to having to just try to plead their case all the time. And it's also good to have more consistency within our program, because even within our own sites, we had techs that would be really good about changing patients at one place, but then they go to a different place within our same system and they wouldn't have that experience. So the techs would get frustrated saying, well, I change my patients all the time, but I have patients coming in saying, well, I went to such and such site and they didn't make me do that. And it's frustrating. It was frustrating. So that was it was something to help kind of with that standardization too. And I think the feedback has been really positive so far.
Perfect. So, have you seen other modalities within radiology conduct their own call to action to address issues within their departments?
Not yet. Yeah, not yet. When we when we first started talking about this, and this was not my idea. I have to give credit to one of our managers, Joy. She's the one that actually even knew of the existence of this within the surgery space, and it just kind of started snowballing from there. Yeah, to our knowledge, there, we even tried to look to see if there was any other department that had done something like this, and we couldn't find any because we would love to not have to start from scratch. Um, so we would literally just had the surgical space to reference, and to my knowledge, there hasn't been any other departments that have conducted something like this since then.
Perfect. Another question here is, what kind of metal detector do you use?
Yeah, well, I can't, obviously I have to preface this by saying, I'm not endorsing any particular product or anything like that. But we do use the PD240CH by CHEIA, CEIA, I believe is how it's spelled. So it actually has it's a little bit different than some of your other handheld wands out there. It has different modes to be able to alert you to both ferrous and non-ferrous metals. And then there's two modes to just alert to ferrous metals only. And another nice thing about these particular metal detectors is they don't emit their own magnetic field like many of the other ones do. So if you're used to hearing, oh, you can never use a metal, a wand over a patient's pacemaker or a stimulator, or you can't use it over their eyes or something like that. That is primarily because of the interference that it would have, with the magnetic field that it's created by the wand. But this one does not do that. So this one is actually approved to be to be scanned over pacemakers and different things like that.
Okay, another question here is, I thought that Freestyle Libra 2.3 glucose monitors were approved to leave for MRI scanning. Is it based on Tesla's strength?
No, it's a good question. So yeah, they are. So Libra Freestyle 2 and 3 are MR conditional now for 1.5 and 3 Tesla, but you still have to remove the. I think there's still a piece that you have to remove, like the actual sensor itself, that's like on the patch can stay. And I apologize, I don't have a glucose monitor myself, so I don't have firsthand experience with them. But there's still like an processor that, like, I believe snaps onto the area that does have to come off, I believe. But it is still something that we want to check for when we're screening patients, because obviously if they have an older model of the Freestyle Libre, or if they have a Dexcom or something like that, then we obviously want to catch those and prevent them from being harmed. And I did also, before we got too far into the call to action, I actually did a little study myself where I went over to a department of ours and got my hands on virtually every model of glucose monitor that's out there, continuous glucose monitor. The only one I couldn't get my hands on was the Eversense, but it is MR conditional anyway. And I was able to take those, and with our metal detector, able to confirm I could detect every single one of those. On the lowest, the least sensitive setting of the wand, I could detect those about 2.5 inches away from the wand. So I would hold it out, as far as I could to see how far out I could detect them, and every single one of them picked up. So that's when we're like, okay, we need to start emphasizing this in these meetings as well.
Perfect. Well, unfortunately, we've come to the end of our hour. So thank you so much, Randy, for your time today and for such a great presentation. As promised, the answer to today's trivia question is dark blue. So congratulations to our winner, Jeff Kennelly in Arizona. And just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 Art Category A CE credit by the AHRA, and you'll be able to download the certificate directly from your computer once the survey is submitted. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and, of course, complimentary registration. If you've missed any of our past ICE webinars, please visit icewebinars.live to view our whole webinar archiving, including the one that Randy mentioned. Thank you all again for your time today, and I hope you enjoy the rest of your day.